Cytoreductive therapy is indicated in polycythemia vera according to ELN, European Leukemia Net, and NCCN, the American guidelines, in patients at high risk for thrombosis. So patients over 60 with a prior history of thrombosis, they should receive chemotherapy or drugs to control myeloproliferation. These drugs mainly are three drugs we have so far. The first is hydroxyurea, that is the standard of therapy. The second drug is interferon, and these two drugs can be used in first-line therapy in patients at high risk for thrombosis. First line means in patients who have who are over 60, 70 years or with a prior thrombosis, arterial or venous thrombosis. And as I said, hydroxyurea is the standard, but the younger patients, guidelines now recommend interferon. And ruxolitinib is recommended in patients who are intolerant or resistant to oncocarbide, to hydroxyurea. Resistant, there is a definition of resistant and a definition of intolerance. In these patients, survival is poor, as corresponds intolerant and resistant patient to 25 of treated patients with hydroxyurea. In these patients, there is a recommendation to use ruxolitinib. But the new guidelines just released by European Leukemia Net recommend also that if this situation occurs in patients younger than 60, you can offer also a new interferon that has been recently approved in Europe and also in the United States, that is the ROPEG interferon. Actually, now the use of this drug can be expanded in subgroups of patients considered at a low risk of thrombosis. Actually, according to the old definition of the risk, that includes, as I said, age and the presence or absence of thrombosis. But now we recognize some subgroups of low-risk patients, younger than 60 without thrombosis, in whom you can propose the use of non-toxic drug that could be interferon or ROPEG interferon.